Today, I'll be talking about the landscape for the prevention of mother-to-child transmission of HIV, or PMTCT, in particular the global gaps and potential solutions. This is intended as an overview with an emphasis on national programs and policy. While I'll touch on some of the interventions, the focus is primarily on approach. Most of the discussion is centered on settings of high HIV burden, but the principles are also relevant to places with concentrated HIV epidemics as well. Over the past 2 decades, we have observed dramatic declines in new HIV cases among children. From 2000 to 2018, the number of cases among children dropped by more than half. And the majority of these infections, still occurred around the time of birth and the months following. Despite the gains made thus far, however, progress has slowed. The global targets for EMTCT were not reached in 2018, and at present, it does not appear that the 2020 targets will be reached as well. While progress in PMTCT has slowed in the global scale, there is considerable heterogeneity by country. This slide shows the HIV transmission rates at 6 weeks, which is shown in green, and during breastfeeding, orange, for the 21 focus countries designated by UNAIDS. Overall transmission rates, as you can see, varies considerably between 2% and 25%. The reasons behind these differences are multifactorial, relating to the characteristics of both the HIV epidemic and its response. As such, the strategies and interventions required to eliminate EMTCT are likely to be different as well. This leads us to the central question for this presentation. At the national level, how should resources be targeted to achieve the goals of EMTCT? It was this central question that drove the development of the last mile to EMTCT operational guidance, supported by UNICEF, the World Health Organization, and UNAIDS. This is a roadmap comprising 4 steps and 8 activities designed to help national programs identify their key programmatic challenges and develop plans to address them. This talk will be structured around the 3 key principles of this guidance, highlighted in yellow here. Number 1, identifying missed opportunities. Number 2, determining programmatic gaps. And then number 3, prioritizing the PMTCT strategies and interventions that best fit these local circumstances. So I'll go through them one by one here. In this presentation, we'll first talk about missed opportunities for PMTCT. Missed opportunities analysis provide a general indication of where problems may lie along the PMTCT continuum of care. Typically, we start by looking at the outcome of interest, in this case, new pediatric HIV infections, to determine what services were, or perhaps more importantly, were not received by the mother and infant. These types of analyses are typically retrospective and cross-sectional in nature, and they may be accomplished in many ways. On a smaller scale, for example, they may be identified via intensive case finding following new infant HIV diagnosis. For the purposes of this talk, we will focus on the country-level estimates generated through the UNAIDS spectrum model. This is also known as the PMTCT stacked bar analysis. In this figure, we begin with HIV pregnant and breastfeeding women living with HIV. Based on the country-level parameters, a spectrum model categorizes women into 7 distinct groups, which you could see here on the right. Starting from the bottom to the top, these are women who started on ART before pregnancy, those who started on ART during pregnancy, started later in pregnancy, dropped off ART during pregnancy, did not receive ART during pregnancy at all, and then 2 categories for new maternal infections, first in pregnancy and then in breastfeeding. In 2019, there was over 1.2 million pregnant and breastfeeding women estimated to be living with HIV worldwide. And you can see how they fall into these 7 categories over here on this graph. The largest proportion are in blue, indicating that almost 3/4 of these women received ART sometime during pregnancy. Next, the spectrum model estimates the number of new pediatric HIV infections that occurred. And here you could see that these scales are slightly different, but there was overall an 8 to 9% transmission rate for just over 110,000 new infant cases worldwide. And among those cases, these can also be further divided up into these different missed opportunities. And the bar graph here now shows the maternal PMTCT status among children during breastfeeding, infected during breastfeeding, and then which is shown on the bottom half of the graph, and pregnancy in the top half of the graph. It is noteworthy, though not surprising, that few infant HIV infections occurred among mothers who receive ART during pregnancy. And that's the different shades of blue that you see here during pregnancy as well as during breastfeeding. However, we find that large proportions of HIV-infected infants were born to mothers who did not receive ART at all, shown in yellow. A substantial proportion were born to mothers who dropped off of ART during pregnancy, shown in gray. And then a significant portion also were born to mothers who were newly infected with HIV, either during pregnancy in orange or during breastfeeding in red. So what I'm showing you here is the global picture. But these estimates can be made at the national level as well. And here are the stacked bar graphs from all 21 priority countries. The scale of these are inconsistent, so they don't accurately represent the relative number of new cases of new pediatric HIV infections in 2019. However, I think the pattern of these bar graphs are what is important, and they illustrate a high degree of variability in the missed opportunities that exist from country to country. And I'm going to show a few examples in greater depth next. So in Botswana, for example, the coverage of ART has been sustained at nearly 100% or at 100% according to these estimates for the last 2 years. And the number of new pediatric HIV cases is estimated just over 200 in 2019, as you can see on the right. The main missed opportunities here came from either women who dropped out of care, as you can see in the gray, or women who were newly infected during pregnancy or breastfeeding, as you can see here in the orange. This is in contrast to the situation in Nigeria. Here, the estimated number of new pediatric HIV cases is over 100 times higher than our previous example. So this is just over 20,000. The missed opportunities that are important here are around the receipt of ART. Large proportions of children who became HIV infected, either during pregnancy or breastfeeding, were born to mothers who did not receive ART, and these are shown in yellow here. And this is consistent with the estimated ART coverage among the pregnant women living with HIV, which has been just over 40% in the last 2 years, and in fact has showed a steady decline over the past 5 years. So next, I want to talk about programmatic gaps. And again, before I talked about, I gave you this definition here on the left side around missed opportunities. I want to distinguish that from these programmatic gaps. Programmatic gaps are related to the missed opportunities, but typically these types of analyses provide more granularity into the challenges that a program might be facing. Data about programmatic gaps can either be gathered prospectively or retrospectively, but typically have a longitudinal component so that women are followed through the course of care or through the continuum of care. And they're often represented by the PMT-CT cascade. Over the years, there have been many depictions of the PMT-CT cascade, and these have evolved as the standard of care has improved, especially in low resource settings. In this example, McNary and colleagues illustrate the important milestones along the PMT-CT continuum of care in the setting of option B+, or universal ART during pregnancy and breastfeeding. Although this framework is more conceptual in nature, it shares many common features of PMT-CT cascades. Number one, there's a stepwise progression between different states. There are parallel progressions for both mother, as you can see here on the top, as well as infants on the bottom. And there's also heavy emphasis on pregnant women living with HIV. For example, in this cascade, maternal cascade, there's not a consideration of women who initially test HIV negative. Those are essentially, those women fall out of the cascade, and the focus is on those who are positive. Here's another cascade developed by Hamilton and colleagues, and this shares many of the same features as before, but here the milestones are mapped to specific process indicators for health delivery. 2 points are noteworthy here. One of them, the first, is that some of these steps are compressed. As you can see here, the steps from ART initiation to delivery are compressed and don't illustrate, what could be weeks or even months of ART use during this time. Secondly, there is an inclusion of women who test HIV negative during ANC, and given the growing contribution of new maternal HIV infections to vertical HIV transmission, this represents an important addition to the cascade. So in the following slides, I'm going to show you how these might map to the missed opportunities. For example, for women who did not receive antiretroviral therapy, you see this is the area where improvements might be made. And it's not just a single step, but in fact, it's comprised of many steps here. For mothers who start treatment late in pregnancy, you see a similar, there needs to be a similar emphasis in this quadrant of the cascade, as well as some emphasis on infant prophylaxis as well. For these next three steps, these are women who initiated ART but may have dropped out of care at some point. And you can see here, again, this part is compressed here, but following longitudinally to achieve viral suppression at various points after, at delivery and then after delivery as well. And then, as mentioned before, for women who are newly infected with HIV during pregnancy and breastfeeding, there should be an emphasis here on the right. Again, this cascade doesn't really talk about the modalities for HIV prevention, but at least it's a start here, talking about the HIV retesting over the course of pregnancy and breastfeeding. So in a recent study by Sabana and colleagues, these missed opportunities here shown on the left were mapped to specific indicators from various data sources shown on the right. For mothers who did not receive antiretroviral therapy during pregnancy, for example, two specific indicators are important. Number one, what is the ANC attendance, as well as what is the ART, what proportion of HIV positive women who initiate ART. And you can get a sense of how these map here. One important feature that isn't included is the timing of the first ANC visit. But from these various sources, you can at least start to see how these two types of data might be triangulated. Here's another example. These are the gray bars that show the number of new HIV-infected infants born to mothers who dropped off of treatment. And here, you can see that in terms of routinely collected data, there really isn't a lot of information gathered here. There is some data in terms of from research, and these are the blue diamonds here that are shown over time, but these really aren't, but again, these data aren't collected routinely by the Ministry of Health or the implementing partners. And this leads to an important final note about programmatic cascades. Even though they're meant to identify programmatic gaps in a directive way, they also help to identify areas where more investment is needed and where better data is needed. And I would make the argument here that better data around retention and adherence would really help this program as an example, but other programs as well, to understand where their gaps may lie. And so lastly, we're going to talk about PMT-CT strategies and interventions and how to prioritize them. We developed a framework to categorize interventions for PMT-CT. And on the right here, you'll see 6 intervention domains. Quickly, HIV prevention services for women, timely access to HIV testing, timely ART initiation, program retention and adherence support, timely engagement in ANC care, and then services for infants at highest risk of HIV acquisition. These domains were then mapped onto the 6 missed opportunities on the left, and you'll see that there's a good deal of overlap between these interventions and how they map along these different missed opportunities. We then conducted a narrative review of interventions and strategies to increase PMT-CT uptake and reduce new pediatric HIV infections. Our time period began in 2013 when option B+ was formally introduced in the WHO HIV recommendations. And here, I won't go through each of them, but you could see the 6 domains, as well as the interventions that are kind of fit within them or categorized within each. These are further classified by the level of evidence available. Again, promising strategies, which is designated by the P, good scientific evidence or available evidence, which is the AE, and then incorporation into policy guidelines, which is the PG. And identifying the interventions that is really an important step to address programmatic gaps. But I would argue that it's the first step, really. What you really need to do is figure out, what interventions work best in any particular setting, and this requires prioritization. On this slide, I list several possible factors that programs might consider, and you could see them here: strength of evidence or magnitude of impact, cost effectiveness, scalability and sustainability, equity and human rights, as well as different characteristics of the interventions themselves: setting, health infrastructure, technology requirements. And prioritization needs to occur at multiple levels. For example, programs must first decide which missed opportunities to emphasize in their planning. Should they emphasize those who drop out of care, for example, versus new maternal infections, and what are the pros and cons of doing one or the other. They also must decide which interventions within each domain would best work to address those targeted missed opportunities. This should be considered both for the adoption of new policies as well as in terms of de-implementation, a critical evaluation of what older policies may no longer be relevant and should be de-implemented. Currently, there are several tools under development to aid such decision-making, though none are quite ready yet. With support from UNICEF, for example, a team at the University of Cape Town is developing a model tool, a model instrument that will show the downstream impact of new interventions for PMTCT out to 10 years. Investigators at the CDC are also creating a catalog of cost effectiveness for different interventions in the context of PMTCT. And when these resources are urgently needed, and I think when they become available, they will really help to guide this challenging process of prioritization. We've discussed the first two steps of this process. Number one, kind of taking stock, and number two, prioritizing and planning. And there is a critical third step here, and that's appropriate dissemination, implementation, and monitoring of new interventions and strategies. And these steps should be viewed as part of a continual and cyclic process for program improvement. Such an approach ensures that ongoing refinement of interventions and strategies for PMTCT, but it also ensures that national programs remain responsive to the evolving needs of the health systems and the patients that they serve. So I would like to conclude. I know I've gone over a lot of these key principles in some depth, but I'd like to conclude by summarizing a few key points from this presentation. Number one, missed opportunities for PMTCT vary by settings. And we've shown this at a national level, but they likely vary greatly at the subnational level, including at the facility, and those should be considered. Number two, data-driven processes can really help optimize EMTCT investments. Some of these data are already available, but some of these data might require further investments for better ongoing monitoring and evaluation. We argue that structured approaches are needed to prioritize these programmatic gaps and their potential solutions, and that program improvement is cyclic in nature and requires ongoing monitoring and evaluation. And finally, in overall summary, we believe that tailored responses are needed to reach the ambitious targets of EMTCT. We've made tremendous gains as a global community, but we're now at a position where this last mile, that does present unique challenges, and we need structured approaches to really identify them and address them. Thank you.